Okay, we're going to get started. People may come in as we start, but that's okay. It's a busy clinical hospital. So I'd like to welcome everyone to the April edition of Medical Grand Rounds. Thankfully back in person. Hopefully it'll stay that way. This is going to be a great talk from a wonderful clinician. A very practical talk as well that we see every day, despite what department you're in the hospital. First of all, though, I'd like to thank Amy Nemster, who's our AD analyst. And these rounds are streamed online and archived on the RVH website. So there's going to be lots of people listening in at home or in their office. And it's also archived on the RVH website for any of your colleagues who couldn't make it. You go back and say, wow, that was a great talk, you should have gone. They can still watch it after the fact. I'd also like to thank Ms. Greens, our education specialist, who coordinates all these rounds and is the linchpin of the educational activities here at the hospital. My name is Chris Martin. I'm an intensivist, emergency physician, and director of care as well as education here at RVH. And it's my pleasure to welcome our speaker today on a wonderful topic, very cleverly named clotting conundrums. Sheilagh Saunders is one of our hematologists here. She's got expertise in both benign and malignant heme. She did her hematology training at Queen's University and was followed by a lymphoma fellowship at the University of Calgary. She came to RVH 5 years ago to start the benign hematology clinic, which has been a wonderful resource for our patients. And she then pursued additional training in acute leukemia through Princess Margaret and the Juravinski in Hamilton. Luckily for us, she now solely works here at the Simcoe Muskoka Regional Cancer Center, and she's here to talk about thrombosis. So let's give a warm welcome to Sheilagh.
Thank you very much. So yes, I'm Sheilagh for those of you who don't know me. So I wanted to go through some thrombosis topics just because they're very common. We see these all the time in the hospital, and they really affect all of our patients throughout the entire building, essentially. And I've already messed up how to make this go forward. I'm sorry to tell you. Doesn't seem to be working.
It might just be, try now.
Okay, great, thank you. Okay, nothing to disclose. So hopefully by the end of the talk, you have a good appreciation for when we choose to use indefinite anticoagulation in unprovoked clots, understand the indications and what is an appropriate hypercoagulable workup for those who've had an unprovoked clot, and then also gaining some practical approaches for selecting anticoagulants in cancer-associated clots, indications for catheter-directed thrombolytic therapy, and lastly for managing superficial vein thrombi. So we have a bit of an ambitious agenda, so hopefully we'll kind of go through things quickly, but I wanted to highlight some kind of common issues that we would get called about from the inpatient floor or common outpatient consults that we would get over in the benign hematology clinic, so hopefully can answer some of your questions. So starting just with a little bit of background information, just to kind of put everything into context. When we're talking about venous thromboembolic disease, that refers really to pulmonary emboli as well as to deep vein thrombi, both in the leg and the arm. I wanted to highlight a little bit of venous anatomy because really the ones we care about here are those deep proximal veins. So in the lower extremity, that's the inferior vena cava, the iliac vessels, femoral, and popliteal. Popliteal does count as a proximal vein, even though it is in the knee. So anything below the knee, therefore, is counting as distal. So that counts as perineal, the anterior and posterior tibials, and then the veins in the calf. The superficial veins, as we'll get to at the last case, we do treat those differently. So it is really important to make that distinction if this is a true deep proximal DVT or versus one of these other veins. Similar in the upper extremity, a lot of our knowledge about DVTs in the upper extremity actually is extrapolated from knowledge from the lower extremity. So again, it is important to make that distinction about what is a deep proximal vein. In the upper limb, that includes the jugular, subclavian, axillary, and brachial. We have a lot of clinical experience, I would say, with basilic and cephalic veins because that's more often or not where catheter-associated clots are found. So PICC lines, for instance, go into the basilic vein. So it's very common to get issues in those. But again, important to make that distinction, superficial versus deep, proximal versus distal. So why do we care about the deep proximal vein? That is because this is really the location that is associated with a higher mortality. So if you do have a true DVT in the leg, there's a much higher propensity for it to travel to the lung and cause a pulmonary embolism. And that's really what's associated with a higher mortality and can be fatal. So these are the ones that we want to treat. And the goal with treatment is to help prevent that clot from extending and then in theory embolizing to the lung. We also know that treating these can help prevent recurrence. So again, the whole goal is to really limit mortality associated with these. Distal clots are less well described. We don't have as much data about them. Not all distal clots need to be treated, and that's really because they don't come with that same risk of embolization and extension. So very quickly, we have a lot of different anticoagulants on the market here in Canada. Right now, the direct oral anticoagulants, so apixaban, rivaroxaban, dabigatran, and edoxaban are the four main ones that we have and use on a day-to-day basis. Right now, based on the test guidelines, these generally are our first line of treatment for most venous thromboembolic disease. There are situations where you might prefer warfarin or low-mercury heparin. So for instance, if there's drug interactions with one of the direct oral anticoagulants, severe renal failure that might be preventing use of a direct oral anticoagulant, we do still use those other medications, but the direct oral anticoagulants really are our first line treatment for most people. This is a very quick comparison of the direct oral anticoagulants. So apixaban and rivaroxaban are the ones that we use most commonly. None of these have ever been compared head to head. So we know that they're all efficacious when compared to warfarin and low-mercury heparin, but they've never been trialed head to head. So we don't know if one is better than the other. So really, when you're selecting a direct oral anticoagulant, what it comes down to is safety profile of these medications, convenience for the patient, so once a day versus twice a day dosing, as well as their other comorbidities. So if you have a higher renal clearance in one of these drugs, you're going to avoid that in someone who has compromised renal function. Lastly, another practical aspect to consider, edoxaban and dabigatran both require an overlap with low-mercury heparin when you start them, which is just a little bit inconvenient for the patient to have to start kind of a subcutaneous low-mercury heparin initially before just jumping right to the pills. So as a result, I would say apixaban and rivaroxaban are really the two that are used most commonly and certainly the ones that I'm prescribing the most. So how do we actually make a choice for an anticoagulant? Again, there's no single right answer, and it really does depend on kind of that gestalt when you're looking at that patient of their comorbidities. Do they have certain contraindications for using a direct oral anticoagulant versus one of the other anticoagulants? Bleeding risk, if they have an associated cancer, all of that kind of goes into making that decision. Patient preference and compliance is also an important consideration. So many people prefer rivaroxaban because of its once daily dosing. So that is something to consider. Apixaban, and again, never been compared head to head, but tends to have a better safety profile in terms of lower bleeding risk. So often that's very attractive for clinicians and patients. Last, but maybe most practically, is actually cost and drug coverage. So for treatment of VTE, there is an LU code in Ontario, but unfortunately it's only good for 6 months. So after that 6-month mark, it can be a problem if someone cannot afford one of these. The direct oral anticoagulants are about $3 a day to use, which doesn't sound like a great deal, but if you're on it indefinitely, obviously that can add up. So really important to explore that with patients when you start that, whether they can continue on with that long term if that may be in their future. I wanted to put a slide on here just about use of the direct oral anticoagulants in obesity, because this is kind of an evolving area where we don't have a lot of data, but need more data. So there's pretty limited data right now in terms of using the direct oral anticoagulants in patients who are at that extreme of weight, and in particular who are meeting criteria for class 3 obesity. So that's a BMI of more than 40. The direct oral anticoagulants, as many of you know, are basically a fixed dose. So everyone takes essentially the same dose, and there's really not a good way of monitoring clinical activity. So we don't know, for many of our medications that are weight-based, for instance, we don't know if it's as efficacious in those people who are weighing more. There is some promising early data from a systematic review that actually showed that rivaroxaban and apixaban seem to be as efficacious as warfarin in those very extremes of weight. But again, this is all retrospective and observational data, so it's not great quality. So it's an area that we need more information in. From a practical perspective, when I'm counseling a patient on using this, I usually tell them that we don't have a lot of information about whether this is efficacious in their weight group. Many patients are okay with that. And again, I usually say that we do have some promising early data to suggest that it is okay, but I always disclose that to the patient that it's not well studied and there's not a good way of measuring it. Okay, so now we'll just jump into the cases. So case one is kind of the meatiest and the longest, so bear with me here, but also probably represents one of the most common questions we get in thrombosis. And that has to do with how long do we anticoagulate someone once they've had a clot and what further workup do we need to do. So Mr. JT, so he's a 67-year-old male. He presents with 2 days of right leg swelling and discomfort. He has an ultrasound done in the emerge, which sure enough shows that he has a blood clot in the popliteal vein extending into the posterior tibial. So that popliteal vein, so that's a true DVT, and it does extend into one of the distal DVTs. He tells you in emerge that this really has come up totally out of the blue. He has not had any surgeries. He's not been ill. He hasn't traveled. He's not on any new medications. This came up totally up out of the blue 2 days ago. He's otherwise a pretty healthy guy. He has some high blood pressure. He's got GERD. He's got fatty liver. He's not on any medications for those though. And in the emerge, some blood work is done, which confirms that he's got a normal CBC and normal renal function. So the emergency doctor starts rivaroxaban at the regular loading dose. So it's 15 milligrams twice a day for 3 weeks, and then 20 milligrams thereafter. But there's concern about how long he needs to stay on this because we think that this is really an unprovoked clot, so it came up out of the blue. So he's referred to you for those two questions. How long do we need to continue this, and why did he clot in the first place? So starting with duration of anticoagulation, so the main thing that dictates duration is whether this is a provoked or an unprovoked clot. So a provoked clot is really anything where there is the presence of a prothrombotic risk factor or an illness that maybe triggered that clot to form in the first place. We often think of transient ones, and that's kind of that classic DVT. So recent surgeries, immobilization, you've been in the hospital, you've been sick, you broke your legs, something like that. And recent, based on the chest guidelines, is within a 3-month time frame. So they're actually fairly generous for that. You know, this could be 2 months after the fact, and that's still considered a provoked clot. Pregnancy, oral contraceptive use, and hormone replacement is also considered a provoked clot. Catheter related, so we see these all the time in the hospital, you know, PICC-associated DVTs. And lastly, there are other provoking factors that are not necessarily transient. So malignancy is a really big one, and may or may not be going anywhere. You know, if this is metastatic and it's being treated but it's not curable, that's something that they're going to have long term, even though it is a provoking factor. Similarly with things like inflammatory bowel disease, other inflammatory or immune conditions. So with a provoked clot, so most provoked clots should be treated for a minimum of 3 months. And after that standpoint, it depends a little bit on that provoking factor. If it's transient, usually you can stop at the 3-month mark. And that's really what the chest guidelines suggest and all of our kind of guidelines about thrombosis suggest. If that risk factor or that provoking factor is not transient and it's still present, basically you continue that anticoagulation for as long as that risk factor is still there. So immobilization, cancer, hospitalizations, you know, if you have someone who's in a wheelchair chronically and they've had what you've determined to be a provoked clot, but their mobility is not improving anytime soon, they should really stay on a blood thinner for that duration of time. So provoked, as I said, 3 months or until that provoking factor is resolved. Unprovoked is where things get a little bit hairier. So we'll dive into that a little bit more. So always, again, a bare minimum of 3 months, and then it depends. When you're making that decision, it's always weighing those two, unfortunately, competing risk factors of that risk of bleeding when they're on an anticoagulant versus the risk of recurrence when you stop an anticoagulant. So it's kind of trying to balance those two things to come up with the best and safest choice for your patient. So who is likely to benefit from indefinite anticoagulation? So in general, most people with an unprovoked clot benefit from long-term or indefinite anticoagulation. And there are some exceptions to that, which I will get into in the next couple of slides. If you've had a recurrent or recurrent unprovoked clots, then we know that benefit is definitely there. So that risk of having another clot is very, very high. Similarly with someone who has active cancer. So they are still being treated. They're very prothrombotic. They are likely to benefit from long-term anticoagulation. On the very flip side of that, those people who are unlikely to benefit, so that opposite end of the spectrum, are people who have a known transient risk factor. So they had a clot because they had a surgery. That surgery, they've healed, their mobility is back. Those are people you can stop at the 3-month mark. We also know, again, looking at that seesaw of bleeding versus recurrence, if your risk of bleeding is really high, being on a blood thinner long-term obviously is going to be pretty risky. So probably those patients are not likely to benefit. There is unfortunately this very muddy gray zone here where there's kind of a lack of data to guide what we do. And those are people who've had recurrent provoked clots. So you have one clot after a surgery, 2 years later, they break their leg, they have another clot. Those we don't have a lot of data for, and that's really guided mostly by expert opinion. In my practice, I've often been continuing those patients on long-term anticoagulation, but it definitely warrants a discussion with the patient about their values and what is meaningful to them. Similarly, unprovoked distal DVTs, which I do have one slide on at the end, we don't really know about those patients. Those are associated with a smaller mortality and tend not to recur as much, but again, we don't have the data necessarily to support that. So when I'm counseling someone who's had an unprovoked clot, these are the numbers that I tell them. So if you've had one unprovoked clot, that risk of recurrence in the first year is 10%, and that actually goes up to 30% by 5 years. So it's actually really high. So usually when you tell people those numbers, they kind of understand why you're recommending long-term anticoagulation. That number is even higher if you've had 2 unprovoked clots. So that's 15% in the first year and then goes up by 7.5% thereafter. So again, for most people in this category, long-term anticoagulation is what I would suggest. Again, on the opposite end of the spectrum, if you've had a transient provoking factor like surgery and then you have a clot, that risk of recurrence is only 1%. So those people definitely usually do not benefit from long-term blood thinners. Other things that weigh into that risk of recurrence, we know that being male actually is associated with a much higher risk of recurrence. So if you've got a male patient who's had an unprovoked clot, almost always my recommendation is to stay on long-term blood thinners. Similarly, recurrent VT, which we talked about, other kind of softer risk factors, the older you are, the more likely you are to clot. We know that higher BMIs are associated with clotting. Smoking is kind of a soft risk factor. If they have signs of post-thrombotic syndrome after the clot, so their leg, months later is still red, swollen, painful, those patients are also more likely to clot. So although there's not a number associated with these are kind of all the things that you take into your gestalt when you're talking to someone about being on long-term blood thinners. So again, going back to that seesaw, so the risk of recurrence versus the risk of bleeding, the tricky part is that we don't have a great way of coming up with a number or an objective way of assessing bleeding risk. There's no validated score for this, so it really is kind of a clinical gestalt when you're looking at the patient. We know that there's certain risk factors that are associated with it, older age, if they've had a major bleed in the past, they've got organ failure, their blood counts are not normal, that all makes you more prone to it. But again, there's not really one specific number or scoring tool that you can use that helps kind of guide that decision. So I've basically said that most people with an unprovoked clot need to be on long-term blood thinners. Are there any exceptions to that rule? Yes, there are, and there are a few validated scoring tools that we can use to help find those people who could theoretically stop blood thinners after an unprovoked clot. The one that I have up here is called the HERDU2 scoring system. This is a Canadian system. It came out of Ottawa, which is why I have it here. There are other ones. There's something called the Vienna scoring system or the DASH model. They're all very similar, but basically it's trying to isolate a small group of patients within that larger group that you could theoretically stop. Again, most people need it, so it is something to consider using if you're thinking about it, but it's usually those people who are really reluctant to go on long-term blood thinners that I'm trying to find this group who it's safe to stop on. This is an algorithm that came out of blood a couple of years ago, and this is something that I definitely use clinically. So this, oftentimes you'll be recommending long-term anticoagulation to a patient, and especially if they're young, there's understandably some pushback with that. So I try to give them a better sense of what that risk of recurrence actually is to let them make up their own minds about whether they would want long-term blood thinners. So at the top here, transient risk factor we've already established. So if you're an unprovoked clot, basically what this algorithm says is that you can then measure the D-dimer and antiphospholipid antibodies generally at the 6-month mark, but they have to have been off of anticoagulation for a month. If those tests are both negative, your risk of recurrence is about 8% for men in the first year and 5% for women. So still not nothing, still actually pretty high. If they're positive, that risk of recurrence goes up to 16% in the first year and 10% for women. And in those patients, again, generally my advice for all comers is to stay on anticoagulation, but some people can use that information to make up their own decisions. So that is something that I will employ if someone is reluctant to do so or worried about that risk of recurrence. A quick thought on re-imaging the DVT. So this is something that we'd see a lot over in the benign clinic, is that a patient has had a clot, 6 months ago, they've been doing ultrasounds every 3 months and the clot is still there. So they've still been on blood thinners. So unfortunately, residual thrombus, so having blood clot there after the fact, is actually really common. So about a third of patients will have that there long term. We know that old clot does increase that risk of recurrence slightly, but not enough to actually make that decision about whether they need long-term blood thinners. So an ultrasound is really not a good tool for helping to make that decision. Having said that, I do still get ultrasounds in these people, really to serve more as a baseline for what is remaining. So if you know what kind of clot or how much clot is there at the end of their treatment duration, and then they've decided to stop blood thinners, for instance, or continue on with them, a year later, they get swelling in that leg again, they get another ultrasound, you have something to compare to say, hey, is this clot new or is this all that old clot from before? So that can be helpful just to kind of establish what things are remaining, but it doesn't really guide what you're doing for the blood thinners. Okay, so then we come to our next question. What do we need to do for this poor man who's had an unprovoked clot, and what workup does he need? So this comes to this concept of the hypercoagulability workup. So what do you need to do to go looking for a cause? And I've split this up into kind of 3 main groups that we think about as kind of potentially associated with clotting. Number 1 is the inherited thrombophilias. So that's a group of kind of 5 disorders that do run in families, and we know that they make you slightly more prone to clotting. There's what I call the acquired thrombophilia. So these are hematologic disorders like myeloproliferative diseases, paroxysmal nocturnal hemoglobinuria, and antiphospholipid antibody syndrome, and last but not least, occult malignancy. So we know cancer is associated with clotting, so the question comes up, well, do I have to go hunting for a cancer in my patient who's had an unprovoked clot? So starting with the inherited thrombophilias, so this incorporates protein CNS deficiency, antithrombin 3 deficiency, and then factor V Leiden and the prothrombin gene mutation. So those are the main 5 that we have the ability to test for. Generally speaking, I do not recommend testing for these in most people with a clot, and that is because this testing is really expensive and it very rarely changes management. So regardless whether or not they have one of these entities, if they've had an unprovoked clot, their risk of recurrence is probably pretty high. So generally speaking, my advice would be to stay on long-term blood thinners regardless of what that testing shows. I have put the homocysteine levels and the MTHFR gene mutation. So hyperhomocystinemia has been associated with clotting more arterial than venous. And the MTHFR gene mutation is a genetic mutation that we can test for that makes you predisposed to have hyperhomocystinemia. These are really not modifiable risk factors, and they're not closely associated with clotting. And there's really nothing that you can theoretically do about them. So if you have hyperhomocystinemia, in theory, you can be treated with B12, which lowers your levels, but it doesn't change that clotting recurrence risk. So again, testing for them is not recommended because it's not something you can do anything about. This is actually just a graph from up to date, but the reason I put it up here is just because it shows what that risk of recurrent VT is with these inherited thrombophilias. So we know that their absolute initial risk is higher than the average population, But interestingly, once you've had a clot, it doesn't necessarily change what your recurrent risk is, other than if you're a compound factor V Leiden prothrombin gene mutation, or if you have antithrombin deficiency. So just to really highlight that knowing that you have one of these, if you've already had an unprovoked clot, really doesn't change your risk going forward, and it doesn't change what we do for your anticoagulants. So are there any exceptions to this rule? And that answer is yes. So there are a very select group of people who might benefit from screening for the inherited thrombophilias. And that is generally young women who are either considering oral contraceptives or who might become pregnant. And both of those can have impacts on what we do for them clinically. If you are thinking that your patient might fall into this category, I'd recommend referring to hematology, because this is someone who's going to need ongoing counseling and testing. So it's something that could be looked for and discussed with a hematologist if that's the case. So this is just showing kind of that risk of oral contraceptives if you have one of these inherited thrombophilias. And we know, again, that risk of thrombus is elevated if you have a very high risk thrombophilia, so antithrombin, protein C or protein S deficiency. So again, something that you might want to know if your patient is considering starting like a systemic contraceptive. And this is just a snippet from the SOGC guidelines. Within that pregnancy realm, they do have specific suggestions about anticoagulation, antepartum and postpartum. So again, knowing that could change management. So these are the instances where we might want to screen for that. The last thing that I'll say about inherited thrombophilia testing is that it's very inaccurate in the setting of an acute clot. So if you have a patient who's been admitted to hospital, they have a fresh clot, most of that testing is not going to be accurate, and that's because anticoagulants themselves can alter those results, and the acute clot itself can alter those results. So if you are thinking about doing this, in hospital is not the time to do it. Do it down the road or refer to a hematologist to determine if you need to do it, because again, most people do not end up needing to have that screening done. So the next group of kind of acquired thrombophilias is this group of hematologic disorders. So screening for things like antiphospholipid syndrome, myeloproliferative disorders, and paroxysmal nocturnal hemoglobinuria. These are really case-by-case basis. So all comers should not be screened for this. If there's something very suspicious in their blood work, so their hemoglobin's really high when they have a blood clot, or their platelets are really high and you're thinking, hey, this could be a myeloproliferative disorder, that would be the time to do it. But it's not something that we're recommending for kind of pan screening in all comers with an unprovoked clot. Elevated factor levels have also been associated with venous clots, but again, this is not something that you can do anything about. So it's not something that we recommend screening for because it's not actionable. And lastly, so screening for occult malignancy. So up to 10% of patients with an unprovoked clot actually do end up getting diagnosed with cancer a year after their clot. And so that's actually a pretty high number. So rightfully so, the question has come up, well, we should be looking for cancers right off the bat when these people have a clot that's found. There have been several studies that have looked into this and looked into the usefulness and utility of this. Notably, there was one out of Ottawa and Canada in general in 2015 called the SUM trial. But basically, the conclusion is that, unfortunately, no, doing a very extensive screening does not lead to any benefit in improved mortality with these patients. What is recommended is what they call a limited screen. And a lot of this would be done at the time of diagnosis anyways, or at the time when you're starting a blood thinner. So starting a CB or looking at a CBC, creatinine, liver function, and then having their family doctor do age-appropriate cancer screening is really just about all you need to do. So further imaging, endoscopy is not usually needed. Unless, again, on history with that patient, there's something very suggestive. So if they started to tell you that they've been losing weight like crazy over the last 3 months and they're a really heavy smoker, then you might go hunting a little bit more. But generally speaking, for all comers, it's not something that we would do. So going back to our case here, so he's a 67-year-old guy. He has this unprovoked clot. He's been started on rivaroxaban by the emergency doctor. He's otherwise healthy. How long do we need to anticoagulate, and what further testing are we going to do? So for him, so he has an unprovoked clot. So he's going to require at least 3 months. And then after that, it depends. But we also know that he's male and this clot has come up out of the blue. So that risk of recurrence is generally at least 10% in the first year and then goes up to 30% by 5 years. So if I saw this patient in clinic, my recommendation would be to stay on long-term blood thinners. What is nice is that we do now have data to suggest that after that initial 6 months of blood thinners, you can reduce the dose to a prophylactic one. And so that's what we typically do for these people who benefit. So do we need to do any other testing? So generally not. He was in the emerge, he had good blood work already done, everything looked normal. You would tell him to follow up with his family doctor just to make sure he's up to date on his age-appropriate cancer screening, and no other imaging or endoscopy is required because he really has no other history that's suggestive or suspicious. All right, so we'll move on to case 2 here. So this is about cancer-associated clots. So Mrs. WC, she's a 55-year-old female. She has stage 1 breast cancer, was diagnosed 3 months ago. She has surgery and radiation, and now she's just on tamoxifen. She also comes to the emergency room because she has new right leg swelling, and an ultrasound shows that she's got a clot in the femoral vein extending to the popliteal vein. So again, one of those proximal deep DVTs. She's otherwise healthy aside from this breast cancer diagnosis. She's really just on the tamoxifen and Tylenol. And she tells you that conveniently she has private drug coverage through her workplace. So this is not going to be an issue in terms of ongoing use of direct oral anticoagulants, and her blood work is normal. So because she's a cancer patient, historically, low molecular weight heparin has really been the gold standard. So she started on dalteparin by the emergency room physician appropriately. Her tamoxifen is stopped, her letrozole is started instead. 3 weeks later, though, she hates giving herself injections and she's fed up with doing them and she wants to switch to a pill desperately. So can she is the big question here. So cancer and clotting is unfortunately a very common problem. So up to 10% of cancer patients will have a clot at some point during their diagnosis. That risk does depend a little bit on the type of cancer. So we know things like ovarian cancer, brain cancer, pancreatic cancer are more likely to be clotty. There's a higher risk if you have metastatic disease and in that first year following the diagnosis. And we do have validated scoring models. There's something called the Carana score, which takes into account some of those factors, which can help us predict what that risk of clotting is. Most of these happen as an outpatient. So people will be getting their treatments and then they present with leg swelling. So it is something that's nice to be able to manage as an outpatient. Generally speaking, most cancer-associated clots need treatment. So much like those regular PEs and DVTs, most people are going to require some form of anticoagulation. This is a bit of a unique population because there are a few risks that are potentially present in cancer patients that are not always present in the regular population, and that includes active bleeding. So if they've got a GI or a GU cancer that we know is bleeding, obviously being on a blood thinner is going to be a little bit riskier. If they've just had a major surgery because of their cancer, if they're on chemotherapy and therefore their blood counts are dropping each month with treatment and their platelets are low, that also can kind of make things a little bit trickier. So it is something to kind of keep in mind when you're seeing these people acutely. Again, generally treatment is for 3 to 6 months or as long as the cancer is felt to be active. So how are we treating these? So again, historically, this was always with low molecular weight heparin. And that comes from these kind of seminal trials, in particular the CLOT trial, which showed that low molecular weight heparin was superior to warfarin in the cancer population. Fortunately, in the last few years, we have new evidence to say that the direct oral anticoagulants are also non-inferior to low molecular weight heparin. So this has opened up using those more routinely in the cancer population. Edoxaban was kind of the first one that was studied in this indication, and that was with the Hokusai VTE trial, which I think came out in 2017. So it's been around for a while. But they kind of had the market cornered for a little bit. Subsequently, the Caravaggio trial has come out, which is a big trial looking at the efficacy and safety of apixaban in this group. We do have the SELECT-D trial for rivaroxaban, which is a smaller one. But basically, just to say, all of these now have evidence to say that we can use them. So this very first trial, the Hokusai VTE trial, which looked at edoxaban, this is just to illustrate the outcomes of that trial. And this basically was a composite endpoint of recurrent thromboembolism and then major bleeding. And so you can see on the left here that the edoxaban actually had a lower rate of thromboembolism, but this was offset by actually a higher risk of bleeding. So overall, it kind of came out that they were equal and non-inferior, but if you break down it by outcome, they did have kind of some different pros and cons. Overall survival was no different between the group. When they broke down the bleeding risk in the edoxaban group, they actually found that it was mostly patients with upper GI cancers, and that's because they were bleeding from there and there's not a good way of stopping it. Similarly with the Caravaggio study, so this was looking at apixaban. Again, apixaban actually was non-inferior to dalteparin in terms of clot recurrence. And interestingly, there was not that same signal for bleeding. So they were found to be essentially the same in apixaban. So overall, we do worry about bleeding when using direct oral anticoagulants in the cancer population because of those kind of initial seminal trials with Hokusai BTE. The major bleeding overall is about 4 to 7%. So it is something that we're careful about. It was not seen again with the apixaban, but we are very careful, and in specific in those high risk groups for GI cancers and GU cancers where there could be ongoing bleeding, that there's not an easy way of stopping them. So I do think people are becoming more comfortable with this. I'm certainly seeing it used more and more in the cancer-associated population, which is great. There are still times when low molecular weight heparin might be preferred, and that is if you've got one of these GI or GU cancers or if you've got active bleeding. The other time is if you know, again, if someone's on chemotherapy and their counts are going to be dropping all the time and making being on an oral anticoagulant more difficult. The beauty of low molecular weight heparin is that you have a shot in the morning. If you don't get it the next day, it's out of your system. So it gives you a little bit more flexibility if you are high risk for bleeding. Direct oral anticoagulants are not proven to be safe in pregnancy and breastfeeding, so that's not unique to the cancer population, that's just in general, but we still wouldn't use those. And really it comes with a few major pros, and that's really ease of administration. So people are not having to give themselves sub-Q injections, which most people really detest. So when is it okay to use a DOAC? So basically I kind of run through this kind of practical and fairly simplified approach about when I'm thinking about when we can use this. So if you have a patient in front of you, they have cancer, they have a clot, first question, do they have a non-GI or non-GU type of malignancy? If the answer is yes, then you're probably okay to go ahead. Is the bleeding risk low? Yes, you're probably okay to go ahead. No drug interaction. So this is an important one and especially unique to the cancer population. If they are on specific chemotherapies, it would be important to make sure that a pharmacist is involved to make sure that it's safe to use from that perspective. Is renal function okay? And last but not least, can they afford a DOAC? So if you can answer yes to all these questions, generally it's probably okay to start it. There are still some exceptions here. So when they did find this increased risk of bleeding in GI cancers, that was really upper GI, and you can imagine some exceptions. So for instance, someone's had limited stage colorectal cancer, that's been, removed, they have no cancer remaining, and then they have a clot. Their bleeding risk is actually probably relatively low. So for them, it might be okay to start a DOAC, but again, would warrant a conversation with the patient so that they understand the risks. This is kind of a similar setup. This actually came from a talk given to us by Agnes Lee, and again, just kind of a practical algorithm to determine if it's something that you can do safely. So going back to case 2, so she's had her breast cancer treated, underwent surgery and radiation, and now has this proximal DVT. So can she switch to an oral agent? So does she have a non-GI GU type of malignancy? Yes, she has breast cancer. Is the patient's bleeding risk low? Yes, she's healthy. She doesn't have a lot of other comorbidities. She's not on any blood thinners. We know CBC and renal function are okay, so that's okay. Absence of drug interactions, she's just on the letrozole now. Your pharmacist gives you the go-ahead that that's okay. Renal function is okay. She's not morbidly obese, and she has private drug insurance. So she is someone who we could definitely consider switching to apixaban and improve her quality of life. So she starts apixaban, she continues this for 3 months. Her cancer is felt to be in remission, and because she no longer has that provoking factor present, she's able to stop at that point. All right, so case 3 and 4 are pretty quick, so we'll try to get through them quickly. So case 3, so this is the role of kind of interventional or thrombolytic therapy in lower limb DVTs. So Mr. BF, so he's a 57-year-old guy. He comes to the emerge with a 24-hour history of severe leg swelling and pain. He tells you he actually had a knee replacement 2 months ago, but otherwise he's totally healthy. He's not on any other medications, really doesn't see his doctor for anything else regularly. He's playing hockey all the time, and he's very happy to have his knee finally replaced. So he gets an ultrasound in the emerge, and this also confirms a very extensive DVT starting up into the common iliac vein and going down into the common femoral vein. And on exam, he has a pretty ugly looking leg, so I'll flip to that slide. But the question is, besides just anticoagulation, should he be receiving something more intensive like thrombolytic therapy? So this is what his leg looks like. So The concern with these is always this entity called phlegmasia ceruleus dolens, which is basically a fulminant massive venous occlusion, which leads to limb ischemia, and unfortunately can lead to leg amputations and also a very high mortality. They don't always look this bad, so it is important to have that in the back of your mind, and it needs some clinical judgment to determine if there's an element of ischemia present or could potentially be present. What are these interventional therapies? So systemic there's three kind of main ones. Systemic thrombolysis is where a thrombolytic is given throughout the whole body with the goal of breaking down the clots that are there. It works, but obviously you're putting that thrombolytic agent through your entire body, so it comes with a much higher bleeding risk. So catheter-directed thrombolysis is really what we use here, and that's really where a catheter is inserted and then typically TPA is applied to that area of clot, so it's really just this localized effect. It is done here through interventional radiology, and then they're monitored in the ICU afterwards. Usually before and after they get that, they're on unfractionated heparin, and then they would be switched over to a kind of a regular oral anticoagulant thereafter. There is also mechanical thrombectomies where you'd actually go in and physically remove the clot. Those are not done frequently just because they're more invasive. The benefit or theoretical benefit of doing these interventional therapies is that it very rapidly relieves that venous obstruction. So if you've got ischemia, it's a really fast way of getting rid of that blockage so that blood flow is going back there. Generally speaking, these are reserved for patients who have this limb-threatening or very ischemic type of clots. And they also have to be fairly massive and pretty higher up. So we know they work better if it's like an iliofemoral DVT as opposed to a lower one. So right now in the chest guidelines, for most comers or for all comers, interventional therapy is generally not recommended unless it's a very specific circumstance. So most of the time, systemic anticoagulation is enough. Where they recommend it is if patients have very severe or limb-threatening DVT, where a rapid thrombus resolution is needed. Why we worry about this is because of that risk of bleeding. So because you're giving a thrombolytic, it does come with higher risks of bleeding. So it's not something we're throwing around willy-nilly. So who might you consider this for? So again, this is just kind of a practical approach or kind of a checklist for people who might benefit from this. So if they have a very extensive iliofemoral thrombus, so again, this higher up in the iliofemoral region are the ones who benefit, not these people who have like femoral popliteal clots. Evidence of limb ischemia or a high suspicion that the limb is going to become ischemic. The other thing we know that for this to be effective, that clot has to be fairly recent. So symptoms have to have been there for less than 14 days. If it's there for longer, there's kind of a component of chronic thrombus potentially already, and then we know that thrombolytics are not as effective. The patient also has to have a fairly good functional status and low bleeding risk, and that's again just because of that risk of bleeding that comes with this. And again, most patients do not need this, but it is something to have in your back pocket if you're seeing a very horrible, phlegmasia ceruleus dolens in front of you. So where does that data come from? So there have been a few trials actually that have tried to look at the benefits of doing this and, why don't we do this for more people? The biggest one was actually this ATTRACT trial, which came out a few years ago. And basically they found that there was no major differences in post-thrombotic syndrome, recurrent DVT, quality of life, or death in patients who received some type of an interventional therapy versus just regular oral anticoagulation. So for that reason, it's not something that's done often. There have been other smaller trials subsequently, which actually show that potentially there may be a benefit in post-thrombotic syndrome long-term in patients who have a very massive clot and have very severe post-thrombotic syndrome afterwards. So some of those studies are a little bit controversial, but generally speaking, the risk of bleeding is felt to outweigh that potential benefit of post-thrombotic syndrome. And this is just kind of a picture from the ATTRACT trial, which shows kind of those relevant points here, so that there is a higher rate of bleeding in these people who had thrombolytics, and that's on the left-hand column here. But there may also be a slight improvement here in those very severe post-thrombotic syndrome patients. So let's say you give one of these thrombolytics, what do you do afterwards? So these patients do still need regular anticoagulation following the thrombolytic. So they need to be switched over to systemic anticoagulation, usually within 12 to 24 hours, and then continue for a minimum of 3 to 6 months. And again, that kind of depends on why that clot came up, if it's provoked, unprovoked, and what their symptoms are. There is a bit of a gray zone here again because it's not well studied. Many expert recommendations, if you've had a really big clot that has needed thrombolytics, 6 months often is recommended, and then make that decision. But again, that's really more expert opinion as opposed to any hard data guiding that. And then what anticoagulant you use is also a little bit controversial. Again, no good data to suggest this. Many experts actually recommend staying on something like low-mercury heparin for a month and then switching over to an oral anticoagulant. I think that is changing because, again, there's no data to support that. So it kind of depends on where you are and the practice and the patient in front of you. So back to our poor Mr. BF here. So is he a candidate for interventional therapy, and what do you do with his blood thinners following this? So you see that picture and you say, whoa, this is phlegmasia ceruleodolens, he's going to lose his leg. So he's someone absolutely who would benefit from a thrombolytic. So he started on unfractionated heparin, he's referred to IR, he gets his catheter-directed thrombolysis. 24 hours later, a venogram's done, the thrombus is gone, which is great. So he's transitioned from all unfractionated heparin to apixaban, and then referred on to hematology. The decision is made to continue his blood thinners for a total of 6 months because he had a very extensive clot at baseline. And then after that, it is ultimately stopped because this was presumably triggered by his knee replacement surgery, which he'd had a couple of months previously. Last but not least, this one's also really quick. So treatment of superficial vein thrombi. So she's a 74-year-old female. She comes in with some anterior thigh pain. She remembers getting kicked in the thigh by her grandson, but really no other trauma or anything else that happened to her. She's pretty healthy for a 74-year-old, so just hypertension, dyslipidemia, and osteoporosis. You get an ultrasound, and it shows that there's a thrombus in the greater saphenous vein. So going back to our anatomy here, what is the greater saphenous vein? So it's a superficial vein in the leg that is proximal, and it's a pretty big one. So people can actually be pretty symptomatic with these superficial vein clots. These are common, so a lot more common than DVTs and PEs, and we diagnose them fairly frequently. What's nice about them, though, is even though they're annoying and painful, they, again, don't come with that same risk of growth and embolization and mortality that a regular DVT does. So they don't all need to be treated. These come up in very similar situations as DVTs, so immobilization, surgeries, hospitalizations. So how do we diagnose these? These have to be confirmed on an ultrasound. And ideally, the report should include the length of the thrombus and how far away it is from the deep system, because that will directly impact what you do with your anticoagulation if you need that at all. And the other important thing is to rule out a concomitant DVT. So some people with really extensive DVTs can actually have extension into the superficial system. So just because they see it in one spot doesn't mean that there's not other clot in the deep system. So you do need to make sure that there's nothing else more ominous going on. So this is a algorithm from Thrombosis Canada, which has excellent clinical guidelines. And this is really what I use when I'm presented with a superficial vein thrombi and what do we do about it. So once you've had that ultrasound, you know that there's no DVT, you know this is all superficial, what do you do with it? And hopefully you can kind of read it up there. But basically, if it's within 3 centimeters of one of the deep veins, we essentially just treat that like true DVT. So those patients get put on full dose anticoagulants for a minimum of 3 months and then decisions made thereafter. If it is a really long clot, so it's more than 5 centimeters or they're really symptomatic, but it's actually pretty far away from the deep system, in those situations, we sometimes can use either low dose or an intermediate dose blood thinner, really for symptom relief and to help prevent it from getting any bigger. And the last box here, it's not very big, so it's less than 5 centimeters in size, and it's more than 3 centimeters from the deep system. These are people that we can often treat fairly conservatively with either topical or systemic NSAIDs and like a warm compress. So the main one we consider if you are going to start treatment in that group that are symptomatic, it's a big section of clot. You can use low-mercury heparin at kind of a low or intermediate dose. These are essentially prophylactic doses. There is data to support the use of both fondaparinux and rivaroxaban at lower doses. So these are the ones that are often used. And that comes from this trial, the Callisto trial, and then the Surprise trial. So rivaroxaban, I would say, is our go-to just for ease of administration and cost. So it's 10 milligrams that you use for 45 days. We do always have to make sure that we're not missing any risk factors for extension. So in very high risk people, you might choose to opt for kind of this low dose or prophylactic dose anticoagulation. So if they're hospitalized, they have an active cancer, these are people you might consider treating even if they're not meeting that 5 centimeter length threshold, just because they're at risk for extension. One slide, which is probably confusing, on isolated distal DVTs. So again, going back to our chart here, this is not a superficial clot, it's a true deep clot, but it's below the knee. It actually has kind of a similar way of thinking to this compared to the superficial clots, and that is we treat that depending on how long it is and how close it is to the deep system. If it's close to the deep system, it's treated like a true DVT. If it's far from the deep system, this is something that you can potentially just monitor for a couple of, like a week or two with an ultrasound to ensure that it's not progressing or propagating. So back to our case here. So she has this area on her thigh that's really painful. There's a thrombus in the greater saphenous vein. What are we going to do about it? So first of all, we need to get more details. So unfortunately, the reports often do not include how long that thrombus is or how close it is to the deep system. So you call up the radiologist and they say that the thrombus is actually 4 centimeters in length, so it's pretty long, but it's fairly far away from the deep system, so it's 4 centimeters away. She has no other real high-risk features or risk factors. You talk to her about just using NSAIDs and she's like, great, that sounds excellent, I'll just take that option. So that's what you start with. Unfortunately, 2 days later, she comes back. Her pain is a little bit worse. You repeat an ultrasound. It hasn't extended, but she's pretty bothered by those symptoms. So in that setting, you actually just start this kind of intermediate or low dose rivaroxaban for 45 days because of severe symptoms and then stop. So that is the end. So hopefully we've kind of met those objectives. So again, just kind of reviewing, most people with an unprovoked clot need long-term anticoagulation. Most people do not benefit from a very extensive hypercoagulability workup. Cancer-associated clots, we're using those direct oral anticoagulants more and more, but again, make sure that you're meeting that checklist of who is safe to do so. Thrombolytic therapy, most patients do not need this unless it's limb-threatening or there's ischemia present. And lastly, superficial vein thrombi and irritating, and no one really knows what to do with them, but hopefully that kind of approach is helpful. Thank you.
I want to thank Sheilagh for a wonderful talk. I have like a page of pearls from that one, so that's awesome. What other questions for presenters, or got a couple? I was going to do it first. First.
With respect to the inherited thrombophilia, is there any value in somebody young, unprovoked DVT, testing them and considering a family perspective?
Good question. So that's a question, I'll just repeat it so everyone can hear. It's just, if you have a very young person who has a positive family history, is there benefit in screening for inherited thrombophilias in those people? It depends where you read it and what your take is on it. Many experts would suggest screening for them in those instances because you are slightly more likely to pick it up. The flip side of that argument is that it's not going to change management. So knowing it is not going to change anything. Some people really want to know. So this is one of these areas where it wouldn't be wrong to refer to hematology, to have a discussion with the patient and tell them the pros and cons of doing that screening, if it's actually going to benefit them or make them more worried. Some people really just want to know, or they want to be able to tell their kids that they have this inherited condition. Other patients would be like, I'd rather not know, like, let's leave it well enough alone if it's not going to change anything else we do. So it depends. Good question. Yes.
Your contraindications to anticoagulation in a patient with cancer, you had 2 different thrombocytopenia thresholds, 20 and 50.
Yes.
And how would you decide which threshold to go by?
Good question. So that depends a little bit on the dose of anticoagulant that you're using. So 20 to 30 and 50. So I would say generally full dose anticoagulation is contraindicated if your platelets are less than 50. If you are on kind of a prophylactic or intermediate dose, it's contraindicated less than platelets of 20 to 30. And again, that's a little bit of it's not a hard and fast contraindication. It kind of depends on the patient and how bad their clot is and what you're treating. So that's why there was a little asterisk there as well, being like, take that with a grain of salt.
Questions? I have one about dabigatran and edoxaban. So the usual dabigatran trials and the initial edoxaban trials for cancer, is the low molecular weight heparin for 5 days a trial issue, or is it a mechanistic issue?
Good question. I think it was the trial issue. I think that's just how they designed it for edoxaban anyways. I'm not sure I know the answer to that for dabigatran. I don't know if other hematologists in the audience know the answer to that question, but a very good one. I think edoxaban is just because that's how they designed it to make sure it was safe, essentially.
I thought it was because, again, dabigatran was going as warfarin, and the gold standard of warfarin was they tried to match them, but I know
Yeah.
there's a mechanistic reason to do that.
Yes, that's definitely true for a doxpan. I'd have to look it up for dabigatran. Good question.
The other question I have is limb-threatening ischemia. Often we get calls from interventional radiology saying we've got a patient we want to do. They've got a big clot, it's going into the iliac vein. We want to do catheter thrombus, but you got to tell us if they need it or not. And I guess that subjective is possibly going to develop limb-threatening ischemia is challenging. I mean, how do you define, like, obviously the cerebral radiology showed us is obvious, but what is it, like, is it sensory changes, and what else do you look for to say, like, yeah, catheter therapy might be good for that patient?
Yeah, yes, I think all those clinical signs, pallor, coolness, loss of sensation. I do think the size of the clot inevitably kind of frames how you're thinking about it. Like if you know it's really big on imaging and it's looking a little bit sketchy, or their leg is absolutely ginormous, that's going to probably push you into that category. It is very clinical, and you're totally right. There's not really kind of a hard, fast rule for it. And the truth is, it's almost never hematologists making that call either, right? Like we often get called to see these people the next day. It's usually you guys who have to make that decision. So my hat's off to you, because I appreciate that that's not always easy.
Yeah, especially within the trials of most well, it's really, a lot of patients not a lot different, because we have a very good interventional radiology team who are happy to do those at
Totally.
times. So it's like, yeah, we would use it, but like it's like patient patients.
Yeah.
Do it to your side. So.
In my experience, I feel like we do it more here than where I have worked previously. But again, I'm never there on the front line to like see the patient to be like, oh, I wouldn't have done it there. So it's hard to know. But I do think that in general, the numbers seem to be higher here compared to where I've done before.
Any other questions? Okay, thank you for an amazing talk. Thank you everyone for coming, and have a wonderful day. Please